Okay, so we at 60. I think we should probably start. So let's see. So welcome everyone to the School of Public Health and Family Medicine's noon meeting. I'm Klaus van Presenting, the head of family medicine here in the school, and it's my privilege to extend a warm word of welcome to everyone who is joining us today, and especially to Nabeela Amien. Thank you very much for availing yourself for this presentation. I will just by way of a short introduction introduce Nabeela to the audience. So Nabeela Amien is a born and bred Cape Townian, I see from her CV. She also did her undergraduate training at Stellenbosch University, and after which she did the internship in Cape Town, Mitchells Plain District Hospital, and then also did a community service in Hermanus. And afterwards, she joined our program in 2018. So she's a final year registrar in our MEd program. And so today she's going to present on her MEd research, which she has already successfully passed. And also, just by way of also saying that I know she was one of our registrars who participated in the national exit exam, and we hope to hear the outcome and the good news any minute, any day from now. So I think we are all quite anxious about knowing and learning the outcome of the exam. But what we are really proud of what Nabeela has achieved, and at the moment she is actually filling in for one of the family physician supervisors at False Bay Hospital in Fishhook, where she's completing her final rotation as part of her MEd and registrar commitments. So over to you, Nabeela. Maybe also just in the absence, thank you also to her supervisors, and I'm sure you're also going to acknowledge them, but for sharing this journey with you as you've successfully mastered your master's level research. So we look forward to your presentation. Colleagues are reminded to maybe just switch off their microphones, and if there's, we will also have time for Q&A afterwards, but you're welcome to also pop a question in the chat during the presentation. The presentation is being recorded, as I know some colleagues, especially those engaged in the clinical services, are not able to join today or during this time, but we will make the recording available afterwards. So thank you for agreeing to that as well. Over to you, Nabeela. Thank you very much.
Thank you so much, Prof. Klaus, for that really nice introduction. Thank you so much, everyone, for attending my talk. I really appreciate it. I'm going to start, and I'm going to turn off my camera for the talk. So I did my research on, my research topic was preparedness for pediatric CPR amongst doctors in Cape Town. And my two supervisors were Dr. Graham Brezick. He was working at UCT, and then many of you may know Dr. Katja Evans. She's currently an emergency medicine physician at Mitchells Plain Hospital.
Nabeela, you're muted.
Oh, sorry. Can you hear me now?
We can hear you. Thank you very much.
Did you hear me? Did you hear me start in the beginning?
Yes. We just learned also the where Katja Evans is based at the moment. Yeah.
Okay. Sorry. So I noticed that there was a lack of literature on preparedness for pediatric CPR amongst doctors in Cape Town, and I specifically noticed this in the various places that I worked as well. And that's why I decided to do a study that aimed to assess preparedness for pediatric CPR in doctors working in Cape Town provincial government primary healthcare facilities. And I specifically focused on knowledge confidence and then doctors' knowledge of equipment availability. So the objectives of the study was to assess the knowledge of pediatric CPR amongst doctors in CHCs, CDCs, as well as family medicine registrars, as well as to assess the confidence of these doctors in initiating pediatric CPR, and then also to assess the availability of equipment required during pediatric CPR from the primary healthcare doctor's perspective. So the important thing about the last point was that I did not do an audit of equipment that was available in the facility, but I looked at whether doctors knew which equipment was available in their facility. So in terms of research methods and design, in terms of the study design, it was a cross-sectional descriptive analytic study using a questionnaire. Sorry, this is a very busy slide, but these were essentially all of the facilities that I looked at. You can just glance at them. And basically, it was all of the CHCs and CDCs situated within the 4 district health substructures in the Cape Metro. And there were around about 9 facilities that I did not obtain research permission from, and those are listed at the bottom. So in terms of my study population and sampling strategy, a total of 173 out of 206 doctors that were working in CHCs and CDCs in the Cape Metro participated in my survey. And the doctors who did participate comprised of interns, community service, doctors, medical officers, family regis, and consultants. I did calculate a sample size that was required before I started the study, and that was supposed to be 134 doctors with a confidence interval of 95% and a margin of error of 5%. So I did capture more doctors than the statistically significant sample size. I also attended each facility multiple times in order to capture each doctor. In terms of the inclusion criteria for the study, so you had to be registered with the HPCSA as an intern, ComServe, MO, registrar, or specialist. And I also included locum doctors as long as they were registered with the HPCSA. And then also people that work, you also had to be essentially employed at a CHC and a CDC at the time of the survey. Exclusion criteria was doctors working in private hospitals and local military hospitals. District hospitals were excluded. And then I didn't include the City of Cape Town primary healthcare facilities because it didn't form part of the Cape Metro. And then certified nursing practitioners were not included. And the reason for this was due to the fact that all the doctors were included in the study. And in most ECs, you have a doctor in it at all times. And essentially, the doctor will lead the CPR team, which is why I opted to exclude the CMPs. In terms of my instrument development, the questionnaire was self-developed because I couldn't find a suitable instrument that measured the 3 main variables in the study. And it contained 2 sections. So section A was the characteristics of the participants and confidence levels, and section B looked at knowledge on pediatric CPR. Knowledge questions were derived from the research of Southern Africa CPR algorithms, and the questionnaire was piloted by 5 doctors. So 2 were emergency medicine physicians, 2 were medical officers, and 1 was a ComServe doctor, and they all worked in a state-funded emergency room at Mitchell's Plain District Hospital. In terms of data collection, the participants were recruited by myself traveling to the study sites, and then I requested that the doctors on site perform the survey. I introduced the study verbally and by way of an information sheet, and then they signed a consent form. They then were given a tablet or the questionnaire electronically, and they completed it under my supervision. And once they completed the questionnaire, they pressed a submit button, and all the results automatically went across to Lime Survey, which is a statistical survey app. And this happened in real time. And then once it went to Lime Survey, it could be moved across to Microsoft Excel for analysis. In terms of data analysis, I used a biostatistician from UCT, and I got permission to conduct the study with the UCT Human Research Ethics Committee, and then all the various metropolitan directors and substructure directors, and then the managers of each facility as well. Okay, moving on to results. So if you look at the characteristics of my respondents, 173 out of the total 206 doctors working in the CHCs and CDCs participated in the survey, which was a total response rate of 83%. 11 results were removed because of incomplete data, and 162 completed surveys were then analyzed. 25% of the sample was medical grade 1 MOs, 30% were grade 2 MOs, and ComServes made up about 15% of the sample, and interns 14%. Consultants and registrars then made up 8% of the sample. I don't have a table of this, but all 4 substructures in the Cape Metropole had similar participant numbers. So looking at the courses completed, the majority of the doctors, to be more specific, more than 74% had never done a course on APLS or pre-hospital pediatric life support or DIPIC. APLS is advanced pediatric life support, and PHPLS is pre-hospital pediatric life support. Also, 63% of doctors had never done PALS and ATLS, which is pediatric advanced life support and advanced trauma life support. Most doctors in the survey, that's almost 90% of doctors, had been on a course, had been on a BLS course. But of the doctors who had completed the BLS course, 28% had completed the course more than 2 years prior to the survey. And 53% of doctors said that the cost of attending a CPR course was a barrier to attending the course. I had quite a lot of tables, so I haven't inserted all of them in. So in terms of performance of CPR in the past year, 58% of doctors had performed CPR 1 to 5 times, 12% performed it 6 to 10 times, and then 11% performed CPR more than 10 times, with 20% never having performed CPR ever. The knowledge of ever in the past year. The knowledge of the average knowledge score that the doctors scored on the questionnaire section was 61.7%, and knowledge scores actually did not differ depending on whether a doctor had previously done a course or not, with all P's being more than 0.05. But there was a trend towards doctors who had done BLS having significantly higher knowledge scores compared to doctors who had never done BLS. Knowledge scores also did not differ by doctors' level of anxiety, but doctors with moderate anxiety had higher knowledge than doctors with high or no anxiety. In terms of knowledge and doctor category, it was revealed that knowledge scores did differ significantly by the category of doctor. So ComServes were noted to have significantly higher knowledge compared to grade 3 MOs. And ComServe doctors also had the highest knowledge scores, followed by interns, then consultants, and then registrars. So grade 1 MOs and grade 3 MOs had the lowest knowledge scores. Okay, moving on to knowledge and confidence levels. So knowledge scores actually differed significantly by the doctor's level of confidence. So doctors who were confident had significantly higher knowledge compared to doctors who were not confident, and doctors who were moderately confident had significantly higher knowledge compared to doctors who were not confident. And knowledge scores actually decreased as confidence levels decreased. Okay. In terms of knowledge and experience performing CPR, knowledge scores differed significantly by doctors' experience performing CPR. So doctors who had never performed CPR had significantly lower knowledge compared to doctors who had at least performed CPR more than 10 times, and knowledge scores increased as the level of experience performing CPR increased. In terms of confidence and anxiety levels, only 25% of doctors felt confident and anxious about initiating pediatric CPR, but just over half of doctors felt anxious about starting CPR, compared to 35% who did not feel confident. And 18% of doctors noted that they felt anxious about performing pediatric CPR because their facility was ill-prepared, with either a lack of equipment or a lack of trained staff. Almost 10% of doctors were anxious about the idea of performing pediatric CPR, as they felt that it occurred too infrequently and 6% felt that inadequate training levels contributed to their high anxiety levels. My last two slides on results. So in terms of confidence levels in performing CPR, so there was no significant association between confidence level and experience level of doctor. But although the results showed no significant association, if you look at the proportions, consultants were the most confident, followed by registrars, whereas MOs grade 2 and 3 and interns were the least confident. Confidence was not associated with having done BLS, APLS, PHPLS, or the DIPIC courses, but doctors who completed the PALS course were significantly more likely to be confident in performing CPR than those who did not complete PALS. Also, doctors who completed ATLS were significantly more likely to be confident in performing CPR than those who did not complete ATLS. So the last bit of the questionnaire was based on knowledge of equipment availability. And if you look at this table, you can see that more than 85% of doctors were certain that the following equipment was available. So specifically oxygen cylinders, electrical wall suction apparatus, suction catheter, adrenaline injection, dextrose 50%, IV dextrose 50%, sodium chloride 0.9%, a defibrillator, and an emergency trolley with a locked medicine drawer and accessories. The doctors were most uncertain, so that's more than 35% of them were uncertain about the availability of pediatric nasopharyngeal airways, oropharyngeal airways, umbilical vein catheters, thermometers, low reading thermometers specifically, a curved stylet, an infant laryngoscope with spare bulb and batteries. The most common equipment that was reported as unavailable, and actually around about a third of doctors thought that this was unavailable, were umbilical vein catheters, intraosseous needles, a heat source, and then pediatric resuscitation algorithms clearly visible. So moving on to the discussion section. I hope I didn't go through the results too fast. In terms of the characteristics of the respondents, the study results we found were based on an adequate sample of doctors working in primary healthcare facilities across the Cape Metro, and as well as an adequate spread of doctors of all grades, apart from registrars who actually only represented 8% of the sample. So the registrars were not really fully representative of the registrar population. In terms of knowledge and pediatric CPR, the study showed that doctors working in clinical settings where pediatric CPR may be required do not meet the required resus guidelines in terms of knowledge. And this is because the average pediatric CPR knowledge score amongst the doctors was only 61.7%, which is significantly lower than the general pass mark of 80% that most pediatric CPR courses require. Research also shows that a lack of knowledge of the guidelines results in an inability to apply pediatric CPR guidelines correctly, and this can result in poorer patient outcomes. Looking in more specifically to discuss knowledge and pediatric CPR, it's actually well documented in studies done globally that knowledge wanes with time. And this is shown in the study with the knowledge levels decreasing as the grade of the doctor increased, with grade 3 MOs obtaining the lowest grading. So essentially the grade of the doctor is a proxy for length of time since last exposure to formal training. However, consultants and registrars performed better on the questionnaire than MOs grades 2 and 3. And this finding can possibly be attributed to their postgraduate training, as well as the finding that more consultants and registrars had done APLS and PALS courses compared to any other grades of doctors. And this, as expected, suggests that knowledge decreases with time since graduation, but education or training increases it and sustains it. So in the study, doctors who had never performed pediatric CPR had significantly lower knowledge levels compared to doctors who had performed it more than 10 times in the past year. Knowledge levels also increased as frequency performing CPR increased. So just over 50% of the doctors had performed CPR 1 to 5 times in the past 12 months, with 20% having not ever performed CPR. And this suggests that doctors do not see many patients requiring pediatric CPR regularly. And this, coupled with the findings of overall low knowledge score amongst doctors, who performed pediatric CPR less regularly or not at all fits in with the study's findings that show that less experience is associated with a lower knowledge score. And the implication of this is that a decrease in knowledge with time since graduation, as well as lower experience levels, is that doctors working in primary healthcare facilities in Cape Town have waning knowledge, and that they see cases requiring pediatric CPR infrequently. In terms of just a little bit more on looking a little bit deeper into the knowledge and pediatric CPR, the study does not show a statistically significant difference between knowledge scores and whether a doctor or not a doctor had previously done a course. But as mentioned before, doctors in the study who had done BLS had significantly higher knowledge scores, and the study therefore does not show any association that attending a pediatric CPR course improves knowledge of pediatric CPR, but the study does show that the overall knowledge of pediatric CPR amongst doctors is low, regardless of whether they ever attended a course or not. And a possible explanation for this could be that doctors do not perform pediatric CPR frequently, also mentioned in the previous slide. So as mentioned, most doctors had never done any pediatric life support course, but most had done BLS. And of the ones that had done BLS, 28% had done it more than 2 years before the study. The results show that doctors are specifically lacking in knowledge that's related to rates of rescue breathing and heart rate needed to initiate CPR, management of VF, and then knowledge regarding chest compressions. The lack of knowledge on ventricular fibrillation is particularly concerning, as it is a potentially reversible cause of cardiac arrest. And furthermore, all of the above things mentioned are integral aspects of pediatric CPR, and performing them incorrectly will lead to poorer patient outcomes. The results therefore show that doctors lack knowledge on knowledge on important aspects of pediatric CPR, and this is likely to be the result of having never attended pediatric CPR training course, having last attended a course more than 2 years prior to the study, or performing pediatric CPR infrequently in practice, as was shown in all of the previous findings. Moving on to the second aspect of the study, confidence levels. 35% of doctors in the study lacked confidence in performing pediatric CPR. Doctors who were confident about performing pediatric CPR had higher knowledge levels compared with doctors who were not confident, even though neither actually had adequate knowledge levels. So in terms of looking at confidence and anxiety, just over 50% of doctors felt anxious about performing pediatric CPR. And the main reasons that were elicited in the survey were ill-prepared healthcare facilities, inadequate training, and that doctors felt that the need to perform pediatric CPR was too infrequent. And the latter fits in with the finding of low levels of frequency in performing CPR. Knowledge scores did not differ by doctors' level of anxiety, but doctors who had moderate anxiety had higher knowledge than doctors who had no high anxiety. And this could mean that a certain amount of anxiety is beneficial, whereas too much or too little is detrimental. But it could also mean that there's no correlation between anxiety and scores. There was no significant association between confidence and grade of the doctor in the study. However, the findings showed that consultants were the most confident, followed by registrars, and then MOs grades 2 and 3 and interns were the least confident. I did mention this before. And this may be explained by the fact that grade 2 and 3 MOs have the lowest knowledge levels compared to the registrars and consultants because they had lower education levels and lower level of course attendance. While the interns, being the most junior, had the lowest experience levels. However, the study doesn't really show, as mentioned, there wasn't really a statistical association difference to that, so it's just pure speculation. In terms of confidence levels in performing pediatric CPR again, although consultants had the highest confidence levels, their mean knowledge score achieved in the questionnaire was around about 60%. While there was no significant association between confidence and grade of doctor, the study shows that some doctors are overconfident in their CPR ability. Confidence levels were not associated with having BLS, PHPLS, or DIPIC, but doctors who completed PALS were significantly more confident in performing CPR than those who had not completed it. As discussed above, consultants and regs had higher confidence levels, and both groups also had high attendance of PALS. And therefore, the results show that higher confidence levels are associated with attending a pediatric life support course. Lastly, the last discussion slide just deals with knowledge of equipment availability. And the study shows that doctors were most sure of the items in their facility being present that were general items used regularly, as well as items that were actually used in adult CPR. So doctors were most uncertain about the availability of items that were specifically needed for pediatric CPR. And this suggests that they've never used these items or very seldom used them at their facility. And a finding that may be explained by the infrequent need, which is a finding that may be explained by the infrequent need for pediatric CPRs at the facility studied. So a total of 1/3 of doctors were uncertain whether pediatric CPR algorithms were posted on the facility walls. And I did feel that considering the low knowledge levels amongst doctors, this is quite a worrying finding. These results indicate that doctors have poor knowledge of the availability of equipment needed for pediatric CPR at their respective facilities. So in terms of limitations, the questionnaire was not a standardized test of doctors' CPR knowledge because it was not developed or measured against an accepted gold standard. The fact that knowledge was also tested on paper is a further limitation of the study, and it would have been nice to actually do mannequin-based assessments. There was also insufficient data with regards to variables measured when comparing knowledge per grade of doctor. As to explain that further, we do not know how long the MOs have been in their current position or when the consultants graduated. The same thing applies to registrars. And furthermore, not all registrars partook in the study, with many refusing, which can cause bias or skew the results. So registrars who opted into the study may have had a special interest in pediatric CPR and or felt more confident because they had attended a pediatric CPR course, thereby introducing a self-selection bias. This was not really the case with the other categories because all but 2 of the doctors consented to take part in the study at the facilities that I attended. Limitations to assessing confidence levels are that it is subjective, as there's no formal tool currently developed that can accurately assess confidence levels for pediatric CPR objectively. In terms of the challenges that I faced, I had to actually make multiple trips per facility in order to include as many participants in the survey as possible. This was because a lot of the time I would go to a facility and one of the doctors would be post-call, or half the doctors wouldn't be there for some reason, or on a different shift. So then I'd have to come back on that shift in order to collect my data. Further challenges included communication with certain facilities. Sometimes the phone lines didn't work, managers didn't respond to emails, and data collection therefore took a little bit longer than anticipated. And also, sadly, while I was waiting the last 5 clinic approval letters, UCT's ethics committee cancelled all human contact research because of COVID-19. So that's why 5 of the 9 facilities that were not included could not be captured. In conclusion, my study shows that primary healthcare doctors are poorly prepared to perform pediatric CPR in their facilities. Regardless of their category, the doctors exhibited low levels of knowledge on how to perform pediatric CPR, lacked confidence levels in their ability to do so, and had poor knowledge of the equipment available in their facilities to adequately perform pediatric CPR. Furthermore, doctors are not attending available courses regularly in order to maintain their pediatric CPR skills. This would result in poorer patient outcomes and increased morbidity and mortality amongst pediatric patients presenting with cardiorespiratory arrest. In terms of recommendations for further research, it is recommended that formal pediatric CPR training every 2 years should be mandatory, and policy changes at local and national levels would be useful to address this. Additional measures should also be put in place within facilities to enhance recollection of knowledge during pediatric CPR. For example, clearly visible algorithms in the resuscitation room of the facility. And doctors should also be regularly educated on the locations and availability of equipment required for CPR within their facility. Further research is needed to determine the outcomes of cases of pediatric CPR within healthcare facilities, and this could be done utilizing data from morbidity and mortality meetings. And also an audit of the equipment available for pediatric CPR within healthcare facilities is also advised, but was sadly not part of my study. And that's the end. Thank you so much for listening.
Thank you very much, Nabeela. I see we have 32 people in the meeting. I know there were some of the registrars that had challenges accessing the meeting. But thank you very much for sharing the results of your very relevant research. I'm wondering if there are any questions from the audience or from the group. You're welcome to unmute yourself or put up your hand, or yeah, this. As colleagues are thinking, may I ask a question? I don't want to put you too much on a spot. But I see there's a comment in a chat. Thank you, Isabel. So great presentation and research. What do you think would be the best approach to improve pediatric CPR knowledge of medical officers on the primary healthcare platform? Should there be a focus on facilitating access to courses or access to exposure at district level ECs? So that's a question about formal training, course-based, simulated versus lived experiential training in an appropriate EC context.
Thank you for the question. What was shown in the study was that one of the barriers to doctors wanting to go for pediatric CPR course, a course, was lack of funding. So I think what would really help would be facilities assisting with funding of courses, as well as giving doctors time off to complete the courses, which was also another barrier that was noted by a few participants. I think that it would be useful to have on-site teaching to groups of doctors on a regular basis, and that would definitely help.
Thank you very much. And there's a thumbs up from the group. Jessica Gammon, thank you. Your question, and after that is Joseph.
Hi. Sorry, Klaus, we interrupted you about to ask your question. Is it okay if I go first, or do you want to
go first? I think I will reserve my question. Maybe it's something other people may have picked up as well.
Okay. Thanks so much, Nabeela, for your presentation. I'm one of the public health registrars, but I was working as a medical officer in a pediatric department before this, so I found your presentation really interesting. I've got a few questions. The first is, do you think that this knowledge of CPR is sort of a dipsticks or an indication for fluid resus or resuscitation in general? I mean, I know that wasn't your research question, but children often will have severe respiratory distress or be fluid depleted before needing CPR. So I'm just curious to know whether it's because CPR doesn't get done as often as other forms of resus for children that you think the knowledge was so poor, or do you think that this is general poor knowledge about resus, including fluid management? So that was the first question. And then I thought that it was really interesting that you've suggested that formal pediatric CPR training be mandatory, and I hear the concerns about the cost. And I mean, it's like 4,000 or 5,000 rand to do these courses, and even if you've done it 2 years before, you have to pay the same amount again. So I suppose another part of the question would be, who should be responsible for this training? And if it's mandatory, you know, should family physicians be training people? Should facility managers? But if they are people who are maybe grade 3 medical officers who aren't the people doing the CPR, they might not be the best to be doing this. Or should pediatricians be stepping in, or pediatric registrars to help? So that's just a question of how how could we think of a way to have an informal course more regularly and provide sort of updated guidelines without going the 5,000 Rand route. And then the third thing, and I'm so sorry for adding an extra comment, but in many of these, or not many of these clinics, but some of them have MOUs attached to them where midwives will be doing CPR quite regularly on newborns, even if it's just airway management and then CPR and sometimes needing to intubate. And at that point, they'd usually call the doctor from the EC if it's in the middle of the night. And I'm wondering whether there was any difference between results from facilities that had MOUs, and I wonder whether if you were to ask midwives in MOUs whether they would actually have really good knowledge of CPR, or whether it is an indication that actually CPR in general, whether it's for a newborn or whether it's for someone who comes into the EC, the knowledge is just as poor. So sorry for having 3 different comments, but I'll leave it there. And thank you so much. I thought this was a fascinating study.
Thanks, Jessica. In terms of your first question, so in terms of the fluid resus side of it, the study, I didn't look at fluid resus or anything prior to pure pediatric CPR. So I'm sorry I didn't share my questionnaire, but essentially the questionnaire focused purely on only pediatric CPR alone. So essentially that's that was what the study was about, and it didn't cover anything before that. So it didn't cover fluid resuscitation or anything else. I'm not sure if that answers your question. And then in terms of who should be facilitating the courses, I agree. I mean, I think ATLS is almost 10,000 Rand now to attend, and you still pay the same amount even if you've done the course before, and it needs to be redone every 4 years, whereas ACLS and BLS together can put you back like 4,000 or 5,000 Rands. I think I paid 6,000 Rand when I did it last year. I wouldn't necessarily say that consultants should be facilitating the courses, because I mean the study showed that consultants also scored about 60% on the questionnaire. So some suggestions could maybe be group facilitation with, if we collaborate with the people that organize the courses, for cheaper rates if we do group teaching, if they come to facilities maybe. And we could also maybe look at something like, you know how they do ESMO training for obs and gynae emergencies, where someone stands with the list and then they practice doing it like once a week. We could look at doing something like that for pediatric CPR, where someone stands with the algorithm and the team then practices doing CPR like once or twice a week on a mannequin. And yeah, the study showed that experience levels were associated with better knowledge. So that would also help with experience levels and increasing increasing doctors' knowledge levels, because they technically be performing CPR even though it's only on a mannequin. I must say I didn't specifically look at any facility, look at the differences in results of facilities that have MOUs. So I can't answer that question, I'm sorry, but it's actually a very interesting question, and I think I will look into it. I still have all the data, so I can.
Thanks so much, Nabeela. And I think, yeah, your suggestion about the ESMO equivalent for pediatrics, I think is an excellent suggestion in making sort of master trainers who can then go to other facilities would be a really great way to address this.
Cool, thank you.
Absolutely, and I'm also just reflecting about how in facility in-service training drills also helps the local team to be aware of the equipment and training needs. Because like I said, I think your questionnaire also said that you didn't necessarily audit the facility equipment, but you asked them, the participants, about their knowledge of what's available. And it's an interesting phenomenon because like you say, I mean, I mean, obviously, having to deal with a child that has now arrested in front of you is something that is almost like what I describe as a never event. You never want to see it. It never should happen. And you would ideally would like to focus your resources in a complete upstream social determinants, all the events that happened before that. So you can, if you focus your attention. So in a way, hopefully, we would, the whole health service and education system is working towards a scenario in the future where there is no need for CPR knowledge because it doesn't happen. But obviously, we know that this is not going to happen anytime soon. And it would be interesting, maybe also to as you review your data set and also plan for future studies, to look at maybe looking at, if it is documented and using data-driven planning to know what maybe the under 5 mortality rate or the incidence of EC-based collapses or resusces or in-facility resus needs are. So to see that correlation, like I say, because I think one of the things that your survey clearly showed is that is also not necessarily the knowledge, but lack of experience. And I think that's where Muzamal's question was also about, is it then necessary to where do all the child resources happen in our system? Really great conversation so far. Joseph was next, and then Marine.
Yes, can you hear me?
Yes, we can. Thank you, Joseph.
Yes, the questions that I have are actually 4 questions. The first one is, as you know, the basis of training and knowledge, we have 3 core competences: knowledge, skills, and attitude. It is very difficult to say that the grade 2 and grade 3 MOs have kind of run out of knowledge, because the MCQs wouldn't assess their skills and attitudes. Probably they would be more superior in that kind of thing. Then again, the demand for research amongst the children, I mean, for the research in the healthcare, in the primary healthcare setting, because I've now been in retreat for the last 3 months, and I've only had 1 research, yet I've been on call almost six times a month. So if in your data you would have captured how much research do they actually have in these facilities, because I have a feeling retention to knowledge is equivalent to prolonged exposure. So you find people in the district hospitals would be more likely to actually manage that kind of research compared to the people in primary healthcare. Because in primary healthcare, you kind of have your more stable child who's about to crash but hasn't crashed. If it happens, it may be a child in trauma or a burnt child. But having a child in very severe distress, maybe following a pneumonia, would be very difficult to find in primary healthcare. They're usually taken away before they need advanced kind of care. So it would be kind of maybe assessing their demand in primary healthcare. How many resources do we have in primary healthcare before gauging the knowledge? I'm imagining if an MO remained in that primary healthcare setting over 6 years, the knowledge on research in pediatrics would completely dwindle if they're in a place like retreat. And case pointing, that research which we had in retreat, there was no IO line. If at all we actually went into VF, there are not going to be any pediatric paddles for the defibrillator, for example. We'd have to use the adult paddles. That would have been interesting to see how it would have gone. And of course, for the IO line, we had to use the needles that we have of different gauges to try and get an IO line. And now that is the kind of thing that normally happens. And then lastly, the translation of the knowledge into the environment. A lot of these courses are set in a very standardized setting, and yet half of our primary healthcare facilities research area is 2 beds, and then an oxygen cylinder, and then you also hope that everything else is there. If you open most of those research trolleys, there's very, very little equipment inside there. Many times the ambibag is of an adult. Of course, you know where I'm going with this kind of thing. Then lastly, the other component that I feel that that wasn't covered was research being a team effort. So one of the things that I first, when I had the research, pediatric research, I had to kind of teach the nurses how to do things. In the middle of the research, I said, no, that's not how you hold the mask. Please hold the mask with a C grip. And now I had to take on that role. Then now I had to go to the role of putting the IV line. So in other words, if you're going to work in that setting, it is not fair to have one-sided. It would have been nice to see how much knowledge do the nurses know. And if the nurses were exposed, for example, in the nurses in maternity, I'm almost sure the nurses in maternity would have known these protocols, probably even more than some, maybe the great ones that you would be looking at, because they are more exposed to this this kind of knowledge. I think those are my questions, comments.
Okay, thanks, Joseph. I'm going to try and answer or comment back to some of what you've mentioned. So in terms of demand for resus, the study did show that that facilities don't see pediatric resus as common. And I mean, according to international studies that I looked at in my literature review, pediatric CPR is actually a rare event. I mean, most even tertiary hospitals see on average less than 10 cases a year. But the reason why knowing how to perform pediatric CPR is important is because pediatric CPR is so life-threatening. So it's one of those things where if you don't do it correctly the first time round, the patient is going to die. And that's why it's so important that you get it, you get your algorithm right the first time. It's one of the major barriers to people. The fact that pediatric CPR is performed so infrequently is one of the major barriers to retention of knowledge, and that's why that's specifically why I looked at this point in my data capturing and made the recommendation that we do educate staff more regularly, because if you do see that one case of pediatric CPR at your facility, it is important that you know how to manage it. Even managing pediatric CPR correctly, even that still has a low prognosis. That's how difficult it actually is to do. In terms of knowledge with regards to the environment, so yes, it would have been nice to do an audit of the actual equipment at the facilities, but that was out of the scope of my study to do that as well. I do think that the doctors' knowledge of which equipment is available does not only reflect what equipment is available, but it also reflects a bit of a dangerous side, that even if the equipment's available, you don't know that it's available. So does that mean that they don't know that they should be using this equipment, or they don't know where they can even get this equipment? And I mean, CPR is such a high-paced event that in the middle of needing to defibrillate a patient, you can't still be thinking, oh, is there a defibrillator here? Where do I find it? You should know exactly where it is. So that's why I did feel that knowledge as to whether the equipment is available was adequate enough for the results of the study. And then yes, with in terms of resus being a team effort, I agree. It would have been really nice to include the nurses, and I'm sure some of the MOU nurses would have really high knowledge scores, because they probably see it a little bit more often than we do with delivering babies. But I opted not to do that, because for the majority of the facilities that didn't have MOUs, the doctor would still be the team leader of the facility.
Thank you. So next is Marine, and then Ahmad.
Hi, Nabeela. It's nice to see you again. Glad to see you doing well, and I've been following your trajectory quite closely since we worked together. So well done, congratulations on the study. I think it was excellent. I found it particularly interesting, your comment about, distance from graduation if you don't continue with postgraduate training, and then the link between that and decreased knowledge, so to speak, and how to manage things. Intuitively, that makes perfect sense. Throughout your conversations with Jessica and I think a little bit with Muzamil as well, we touched on it, how best to go about closing this gap. And while in-facility training is an excellent suggestion, I think that's currently what's going on, should we not push for the Department of Health itself to take a little bit more responsibility in the training of its doctors? The training of undergraduate medical students, it's in part a governmental subsidized procedure. But in enhancing the healthcare throughout the country, it's not just those that can afford it or those that have close proximity to urban settings where these courses are being held, but it's the responsibility of the government to make sure that all of its workers are skilled and knowledgeable in all facets, especially something as life-saving and as important as pediatric CPR, all kinds of CPR, but pediatric CPR especially considering it's such a rare event. The rarity of the event does not negate the importance of doing it correctly or the knowledge that you need in order to do it correctly. In fact, it just heightens it. So instead of putting the onus on, on the consultants or the trained individuals, perhaps there should be more collaboration, and we should take this a lot further than just in facility. And as we do CPD and CME points for increased knowledge and for us to prove to the HPCSA that we haven't forgotten, important medical knowledge or how to administer drugs or which drugs to use, perhaps there should be a mandatory CPD component for skills. Because at the end of the day, it's the skills that are going to make the difference between whether this patient lives or dies. So I think it's a broader topic, and it's something that we need to take forward a little bit more seriously and make it a bigger issue nationally rather than just in facility. Thank you.
Hi, Marine. It's really nice to hear from you again. I agree. I do think it's something that should be addressed higher up, especially with regards to funding. But I also want to say that I don't, and yes, it is part of a much bigger conversation. But I also don't think that it's something that we should be initially advocating HPCSA to put down as a CPD thing just yet, unless we have that funding. So, I don't think it would be fair to force people to do courses that many people can't afford. We don't know everybody's financial status, and if we're going to force people to do a 10,000 Rand course every 2 years, it's not fair to do that unless we've actually funded them, or at least partially funded some of that. So I think the way to do it would be to get the government involved, like the Department of Health involved, and then from there we should make the courses more mandatory. Otherwise, revert back to in-hospital training. I'm not sure if that what you think about that. That's just how I see it.
I wouldn't advocate for it becoming a mandatory CPD thing if the doctors have to pay for it out of their own pocket.
Yeah.
Only if it becomes, I feel like it should be something that is looked at, but that it should be provided for either by the council itself or by the Department of Health. And they should definitely put the bill for that. Because at the end of the day, if you're looking at cost and burden of disease, if you have well-trained physicians and well-trained doctors, you're going to end up saving a lot more in terms of expense rather than trying to fight your way out of litigation battles or dealing with the loss of life, which is oftentimes a lot more severe than it's always more severe than any monetary value. So I think this is something, as part of the bigger discussion, doctors shouldn't be necessarily forking out 10,000 Rand for upskilling of themselves. It should be something, especially if they're working in government, that the government should, if not foot the entire bill, definitely subsidize quite substantially, so that the caliber of treatment that the people of South Africa receive is of the highest standard. And I think that should be the ultimate goal.
Yes, thanks, Marine.
Thank you very much. And I see it also resonated with the audience. Jessica has made a valuable comment in the chat. I want to give Ahmad an opportunity, as I know we're almost on the hour, but Ahmad an opportunity to ask his question.
Hi, good afternoon, everyone. Thank you, Nabeela. Thanks for the interesting presentation. It's really one of the aspects of the primary healthcare family physicians need to look at to improve the service. My question is I'm wondering about the inclusion and exclusion of the population involved in the study. So you excluded the practitioner nurses who are actually in the front line all the times, even after hours, while you included the family physician, the consultants, I mean. Is there like an answer for this question, please?
Hi, Ahmad. Thanks for your question. I don't know if I can go back to my second slide. I'm not sure how to do that now. But essentially, I excluded the nurses because I felt that in every single facility, most of the facilities that did after-hour calls, they always had a doctor on site. And I felt that the doctor would have been the leader of the primary healthcare team in the EC at that point. That's why I decided to exclude the nurses from the study. I didn't exclude primary healthcare physicians from the study. They were included.
Yeah, so just I'm wondering why they included in the study, while the consultants, they're not usually in the resuscitation all the time.
Yes. So the reason they were included is because even though they're not there maybe after hours, they are there during the day. So my study sample included anybody who works in an EC at any time. So the family physicians could be working in the ECs from 8 to 4. And we do also have some family physicians that actually do after-hour calls on site as well, which is why they were included.
Yes, thank you. Thanks, Nabeela.
Okay.
Thank you very much, Ahmad. Yeah, I'm aware that we're at the end of the hour, but I can see from the conversation that we've been having, and maybe my question that I had at the beginning was more around the methods and the actual fieldwork process. I was curious to learn why you felt that it would be more appropriate to almost invigilate the respondents as they completed the survey, and where they, especially with the COVID impact on research, where it would have been simpler to just circulate the survey around, and maybe also knowing that if I mean it certainly helped your response rate, but I was wondering about how it might have affected the participants' engagement with the questionnaire, knowing that you are maybe, I don't know if you were hovering in the background, but like almost like the Hawthorne effect. But yeah, just your thoughts about maybe the actual fieldwork process.
So basically, most of the field work was actually done pre-COVID. So I collected most of my data in December, the year before last year. That was when that specific December. So COVID wasn't really a problem back then. So on-site data collection was still allowed. And I decided to be there while doctors filled in the questionnaire, so that I knew that I could trust the results that I got. So I just felt that if I didn't do it, one of the confounding factors would have been where the doctors, were filling in the questionnaire while looking up the algorithm. So I knew that they weren't doing that, so I could trust the knowledge results that I got, and knowledge was the mainstay of my study. So one of the mainstays. So it was something that I wanted to be very accurate. Yeah. And for most of the facilities I went to, I arranged with the family physician or the clinical manager on site for as many of the doctors to be there. So they'd all be in one room, and then I would send them the link. Most of the time it was on their phones, and I'd just like sit in a corner while they filled it in, and it didn't take more than 10 minutes.
I think that's very valuable, and I think it certainly confirms the validity of your results or the trustworthiness. Like you said, I mean, I would be curious to learn what is if you, from a researcher perspective, what would be your recommendation for next steps in terms of future projects?
I would say that for next steps, I mean, things that could probably strengthen the study would be to actually look at morbidity and mortality reports in facilities, and then link that to the study findings, and then maybe to actually do a proper audit of equipment available in facilities, because then those findings would also strengthen the current findings, and then yeah, take it from there.
Excellent. But I want to congratulate you, Nabeela, and your supervisors for a very relevant research conducted at primary care level, and I'm sure a lot of the findings will also help to affect the necessary change that we would all like to see. Thank you also to everyone who's been on the call for your engagement and great questions and comments. And I think also, maybe also just to conclude, I think that it illustrates that we as family physicians and family medicine registrars should really take charge of that within our local sphere of influence. And especially, I think, as we are part of the teams that have to deal with this, that's the one benefit in terms of our roles, but also having that community perspective. So maybe also, like we said, we acknowledge this is a rare event and we would like to keep it that way, but that we also continue with our public health partners and other colleagues to look at the upstream factors. And I know there's research done by one of our other registrars, Luke Prophet, looking at under 5 mortality and out of facility deaths in children. So I think there's clearly something that resonates with our context, and that I hope and trust that we will continue to ensure that, especially our registrar research, but our other research activities and our training activities are aligned with what's needed in the health services and what's needed for our communities. So thank you, everyone. Have a wonderful day, and I hope you stay warm and safe. And yeah, all the best.
Thank you. Bye.
Thank you, Nabeela. Thanks, everyone.